So welcome everyone. C'est avec un grand plaisir que je vous souhaite à tous la bienvenue. It's my pleasure to welcome all of you to the Interprofessional Grand Rounds hosted by the Office for Interprofessional Education at McGill University. My name is Kelly Root, and I'm an executive member of the Office for Interprofessional Education, and I'll be your MC today. I'm ecstatic to be hosting this event. We had outstanding interest in this event with over 500 people registered from all across Canada and as far as Australia. And we have people from a variety of settings, so from the university and academic settings to hospitals and communities, and with over 10 professions represented, so a truly interprofessional event. As they're all gathered here together today, I would like to take this time to acknowledge that McGill University is situated on the traditional territory of the Kanien'kehá:ka, a place which has long served as a site of meeting and exchange among nations. We recognize and respect the Kanien'kehá:ka as the traditional custodians of the lands and waters on which we meet today. Before we get started, I do have a few housekeeping items. When you came on, you probably realized that your cameras and mics are off. They'll stay off for the presentation as we're recording and we have a lot of people. We don't want to have extra distractions. The talk will be 45 minutes, but there will be a 15-minute question period at the end. You did have an opportunity to submit your questions as you signed up. Some of those questions will be addressed throughout the presentation. And at the end, if you have additional questions or didn't submit your questions, you'll have an opportunity to do that through the chat function. So you can message me directly in the chat and I will monitor the chat and take those up with Dr. Lingard. The presentation is in English, mais si vous avez des questions en français, vous pouvez l'écrire en français, je vais les traduire en anglais. So it is my extreme pleasure to introduce our speaker today. She's an internationally recognized researcher in the study of communication and collaboration on healthcare teams. With over 20 years of experience, she has studied the communication practices of clinical teams in order to support evidence-based educational initiatives to improve teamwork. She is a professor in the Department of Medicine and senior scientist at the Center for Education Research and Innovation, both at the School of Music and Dentistry at Western University. She's a prolific scholar, committed mentor and teacher, award-winning researcher, as well as an honorary fellow at the Royal College of Physicians and Surgeons of Canada. So without further ado, I'll turn it over to Dr. Lorelei Lingard.
Thank you very much, Kelly. I'm going to share my screen and we'll get started. All right. I'd like to begin by acknowledging that I'm speaking to you today from the traditional territories of the Anishinaabe people. And I'd also like to pause at the start of this talk to acknowledge that today is Red Dress Day in Canada. Red Dress Day is a day to honor missing and murdered Indigenous women, girls, and gender diverse people, to remember them and to advocate for change. I'm honored to be invited to give this grand rounds for the Office of IPE on truths and myths about teams, to spend some time this afternoon thinking about what these might be and reflecting on their implications for how we understand competence in healthcare. It was interesting to get questions before I delivered my keynote today. I've never had that situation happen before. And it was actually very useful to be able to read through the page of questions and get some insight into what people are wondering about. And so as I updated my literature and read what had been published in 2020 and 21 and refined this talk, I've woven in some of those topics that you asked about. I look forward to additional questions through the chat at the end. Let's get started. This is Jack. Jack lives in rural Ontario, not far from the farm where he was born 85 years ago. If you ask Jack how he's feeling, he'd say, just fine for an old guy. Jack still drives his own truck, he cuts his own grass, he blows his own snow, he sits on his old boat in the marina in summer evenings and watches the sun go down. He's got a pretty good life, but he is, as he puts it, fed up with all the doctoring. In the last 12 months, Jack has had more than 30 healthcare appointments. He goes regularly to get his INR checked by the nurse at the family health clinic. He sees a geriatric psychiatrist to help with lifelong depression. He's seen a cardiologist, a respirologist, and a urologist for various concerns in the last year. He's been to the dentist repeatedly because a new medication is rotting his teeth. He stumbled getting out of his truck in the spring, and so he's been doing physio for a pulled groin. And he drops in regularly to the local pharmacy to talk to them because they help him understand all his medications. Jack is not unusual. In fact, Jack is pretty average. These are Chi-High data drawing on the 2017 International Health Policy Survey of Seniors, an international survey that compares how Canada is doing to the rest of the world. And that survey reports that 33% of all Canadian seniors report having 3 or more chronic conditions, and that 15% of seniors saw at least 4 doctors in the last 12 months. That's excluding hospitalizations. These seniors have millions of healthcare visits a year. And in our more optimistic moments, we refer to this sort of healthcare landscape, this healthcare situation, as a team sport. No single healthcare provider can care for a complex senior patient. No senior healthcare provider can care for many patients, senior or no. And so we understand and acknowledge and celebrate that healthcare is a team sport. But the metaphor doesn't always hold. Because for patients and their family members who travel their care journey with them, healthcare can feel less like a team sport and more like a maze of disconnected care episodes. This is what I've spent 25 years studying. I've studied all kinds of healthcare teams, and I've been interested in how do they work together? How do they collaborate to address the multiple needs of patients? Because I'm trained in rhetoric, the social study of the uses of language, I always ask questions about how communication plays a role in their collaborative work. I'm interested in the unintended and intended consequences of training for collaborative work. And I've studied teams ranging from contexts like the operating room and the intensive care unit to primary care, internal medicine, pediatric medicine, adult rehabilitation, etc. This is the only method slide I have in the presentation. Most of you, if you know my work, know that I'm a naturalistic researcher. I go into the environment where teamwork is happening, and I and my team members and graduate students hang around and watch and listen, and then talk to healthcare team members about what we're seeing and what we're hearing to understand why things happen the way they do. What is their understanding of how it came to be so? Drawing on that body of work, today I want to hit 5 objectives. First, I'm going to talk a little bit about some truths about teams. And then I want to step back and ask, what do we mean when we use the word competence in health professions education? Then we'll reflect on what I call some myths about teams. And then we'll think about implications for health professions education broadly and interprofessional education more specifically. So first, some truths about teams. I think with almost 300 people on this Zoom meeting, we're going to have a handful at least of social scientists who feel a little titchy, as do I, about using the word truth on a PowerPoint slide and putting a capital T in front of it. Social scientists don't usually do that. But all of these years of studying healthcare teams have shown me that some things do hold true over and over and over again. The first truth is that competent individuals can come together to form an incompetent team. The second truth is that teams can be competent even when a team member is incompetent. This has to be true, or no patient would survive a July 1st admission to a teaching hospital. We rely on this to be true. The third truth is that an incompetent team member can paralyze one team while another team manages to carry on around her. We don't know much about this phenomenon in the research literature on teams. And the fourth truth is that the same team can be competent one day and incompetent the next. Given these truths about teams, my argument today is that we need to change the way we think about competence in healthcare training and practice, because the way we think about competence right now does not explain how these things can be true. How can individually competent practitioners come together to form an incompetent team? These are almost paradoxical truths. They fly in the face of what should seem to be common sense and true. So what do we mean when we talk about competence? Well, Kenneth Burke, who's a 20th century rhetorician, said that every way of seeing the world is a way of not seeing the world. Human beings can't take in everything. We have to be selective in our perception, and language helps us with that. It's necessary, it's a fact. It's not something that we can avoid or undo. Every way of seeing is a way of not seeing. And competence is a way of seeing the world of education. How we see competence shapes our attitudes and our actions, because how we see competence selects some things for our attention and emphasis and investment, and deflects our attention and emphasis and investment from other things. What are those selections and deflections? Are they conscious for us? Are they strategic? Or are they invisible? Well, Kenneth Burke says that they can come to be invisible because ideas like competence rise to the status of what he calls a godterm. A godterm is a term that has such power and influence that other terms are subordinated to it. Competence is such a term in medical and health professional education now. It wasn't 25 years ago when I entered this field. It certainly is now. I like to think of God terms as a kind of rhetorical trump card. Imagine yourself sitting on an undergraduate curriculum committee meeting and someone plays the competence card in their argument for one thing or another. You can't argue against that. It's a trump card. Imagine you're sitting on a hospital quality committee and someone plays this patient safety trump card. You cannot argue against it. These are words, ways of seeing that hold enormous power. And to someone like me who's trained in rhetoric, they are enormously interesting. I want to understand how they work and what they make us do and what they make us believe. So how do we see competence? What is this for us as a God term? Well, conventionally in health professions education, we have a very individualist way of seeing competence. And if I had to boil the individualist way of seeing down to a few key premises, they would be these. That competence is a quality that individuals acquire and possess. They come in without it and we fill them up with it. And therefore, it is also a state to be achieved. You can get there. And although we never say it explicitly, implied in the individualist way of seeing competence is the notion that competence is context-free. It's untied to time and space. If I'm competent today, I should be competent in this regard tomorrow. If I'm competent in Canada, I should be competent if I go to speak in Singapore. The individualist notion, this way of seeing competence, influences absolutely everything we do in health professions education. We try and select the best individuals. Even when we put them in pedagogical contexts that are predicated on team-based learning or small group learning, we tend to assess them as individuals. Licensing and evaluation are individually targeted. The monitoring of licensed practitioners and the remediation of practitioners are all individually based. So what's the problem? Well, the problem with the individualist way of seeing competence is that we know from the quality and safety research that patients can fall in the cracks between individually competent care episodes. Let me tell you a story to give this some texture. This is Catherine Hoopman. She's an 80-year-old woman who's been living with her daughter and son-in-law for the past year. She's had chronic back trouble since a fall a few years ago, and her memory's not what it used to be. 6 weeks ago, Catherine was admitted to hospital with a pneumonia and a worsening of her chronic kidney failure. While in hospital, she also developed an acute delirium due to a drug side effect from her long-acting morphine, which she takes once a day for back pain. This improved following discontinuation of the morphine in hospital, and Catherine recovered nicely from her pneumonia and was discharged home, but now with a new baseline reduced kidney function. A week after her discharge, Catherine, accompanied by her daughter, has a follow-up appointment with her family doctor. The discharge note from the hospital hasn't arrived at the family doctor's office yet, but Catherine brings her pill bottles, including the stopped morphine, which she has restarted because she didn't understand that she shouldn't. Her daughter raises concerns at the appointment about her mother's worsening cognitive function and her agitation, particularly at night. The daughter's exhausted. The family doctor prescribes a new medication to help with sleep at bedtime and arranges for home care support through the community nursing agency. Over the next few weeks, Catherine's cognitive function continues to deteriorate. And despite receiving home care services, her daughter is increasingly overwhelmed. Catherine's daughter consults with the home care case manager and then the family physician, eventually making the difficult decision to have her mother placed in a nursing home. So what's going on in this scenario? Does this resonate with you? This is one of those stories where it's possible that we're seeing a progression of Catherine's dementia, but it's equally possible that better continuity across Catherine's care episodes would have resulted in her acute cognitive decline being resolved. When we look at a situation like Catherine's, we can see that the hospital physicians were competent in their care of Catherine. The family doctor, acting on the most up-to-date information available, was competent in their care of Catherine, and the home care nurse manager as well. But these individually competent care episodes do not equal good quality healthcare for Catherine and her family. And to try and get at this paradox that individual competence doesn't mean good healthcare, I wrote a number of years ago about the concept of collective competence, with which Nick Boreham had written about in higher education previously, and I brought to the medical education setting. Collective competence is a way to see aspects of competence that are not reducible to the individual, but emerge instead from social and organizational systems. And if I had to boil collective competence down to a few key premises, they would be these: that it is a constantly evolving set of multiple interconnected behaviors, and it's achieved through participation and enacted in time and space. It has strong theoretical roots in theories like complex adaptive system theory, which acknowledges that complex systems, like healthcare, are inherently unstable. A change anywhere produces a nonlinear ripple effect, so that competence in such systems is highly context dependent. So what I've sketched for you in this part of the talk is two ways of seeing competence. The first, our conventional way, is to see competence as an individual possession, as stable and largely context-free. I've also suggested that we could see competence as collective, as a distributed capacity that's evolving and very tightly based in situations. It's important that I'm explicit at this point that I'm not setting up a simple binary opposition. Collectivist competence is not a solution to individualist competence. We need them both. They offer something different, but each selects and deflects our attention. So let's revisit those truths that I opened the talk with from the perspective of collective competence. Competent individuals can form an incompetent team because collective competence emerges through social interaction, shared experience, and tacit knowledge. It's not housed in the individuals themselves. It emerges in the interaction. Teams can be competent even when one team member is incompetent Because collective competence is a distributed capacity. It's a joint accomplishment that you can't reduce to an individual performance. An incompetent team member can paralyze one team, while another seems to neutralize that team member and carry on, because how the system responds to the individual is the key, not the individual herself. And finally, the same team can be competent one day and incompetent the next, because collective competence is evolving. It's unstable, and it's tied to the varying resources and limitations of a particular performance context. So we've talked about some truths about teams. I've laid out two ways of seeing competence, and we've revisited those truths with a collective way of seeing to see how we could understand how these paradoxical truths could be true. How can these things happen in a day-to-day basis in healthcare? Now I want to shift to the third part of the talk and reflect on some myths about teams. And this is the part of the talk where I set out on purpose, pedagogically, to make you feel uncomfortable. This is the section of this lecture that I developed after many years of people coming to the microphone when I talked about collective competence and saying, yeah, but. So this is my ode to the yeah buts. The first myth I want to reflect on is this one. If we just all did our jobs properly, then this team would be competent. The second myth is, if we just understood each other's roles, then this team would be competent. If we just had clear leadership, then this team would be competent. Do you hear the nostalgia in that one? If we just had a leader. And if we just all focused on the patient, then this team would be competent. Anybody feeling uncomfortable yet? I've just called patient-centeredness a myth. You should be starting to feel titchy. So, these myths are about excellence, role clarity, leadership, and patient-centeredness. Why have I called them myths? Let's look at another story. Wilfrid Chang is a 56-year-old man with end-stage liver disease. A few weeks ago, he had an admission to the transplant unit for assessment. And during that admission, he was assessed by members of the transplant team for medicine, surgery, and anesthesia regarding his suitability as an organ recipient. In addition to his organ failure, Wilfrid has a heart stent, and that causes anesthesia to be cautious about his appropriateness for listing. The consulting anesthesiologist tells the transplant nurse practitioner that the patient needs a left heart catheterization before transplant should be considered. Wilfrid is discharged home with the goal of building him up nutritionally in the meanwhile. But just over a week later, he's admitted to the ICU, and the morning following his admission, he's characterized by the transplant team at rounds as crashing. They express a real sense of urgency about getting him on the list. They're worried if they wait, he's going to become too unstable to transplant. But before transplantation, that residual issue from the last admission still needs to be resolved. Can Wilfrid's heart withstand the surgery? Answering this question requires the transplant team to facilitate a process of negotiation between the conflicting clinical opinions of the anesthesiology and the cardiology services. So the transplant nurse practitioner frames the situation this way. There was anesthesia, cardiology, and us. And ourselves and anesthesia felt that the patient needed a left-sided heart cath prior to listing for transplant, and cardiology disagreed with that. One of the transplant staff people said cardiology was ordering a CAT scan and it was coronary arteries. And anesthesia said, I don't care what the result is, that isn't good enough, we want a cath. And the cath guy says, well, I'm not doing a cath because you don't need a cath. And anesthesia says, well, we're not doing a transplant then. And we're stuck in the middle going, figure this out. One of the transplant surgeons reflected that sometimes the comment is made by cardiology that anesthesia is being overly cautious. The anesthesia is saying, well, cardiology is not in the OR and they don't know everything that we have to deal with. The transplant fellow explains that the compromise finally between all three services is to order a CT angiogram, which is performed in radiology. But then the radiologist wanted the heart rate to be much better controlled prior to doing a CT coronary angiogram because they felt that the false positive rating would be too high with a high heart rate, and so they didn't want to do the scan. Well, that's quite the story, isn't it? Why have I chosen this story? One of the reasons I've chosen it is that our knee-jerk reaction, I think, is to say, that is horrible teamwork. What is going on here? People pull in the same direction. But in fact, this is the complexity of everyday teamwork. It's not simple. It's highly complex. And why is that so? I want to briefly touch on three factors that I think make teamwork more complex than we usually acknowledge. The first is that roles on a team may be overlapping. In the situation of Wilfrid's transplantation story, who is the heart expert? A number of different members of this team could legitimately lay claim in relation to the question they're trying to answer, that they are the heart expert, not just the cardiologist. The other factor that makes teamwork complex is that authority is negotiated. Leadership is not obvious, and nor is it stable. So who is the most responsible physician in this story? Again, a number of team members could legitimately lay claim to this sense that they ought to have the position of authority in the making of this decision. And finally, and perhaps most interestingly to me as an education researcher, competing motivations in healthcare teamwork make it complex. There are a lot of goals in this situation. There's the goal to safeguard Wilfrid. There's the goal of stewardship of the organ to make sure that the organ goes to a patient who's going to be able to benefit maximally from it. There are also educational motivations. We want fellows and residents to be able to try out communications in this exchange, and that makes things take longer. A transplant social worker on the team had a really interesting reflection. She said, "We're a good team. We like working together, we're committed, and this sort of thing happens pretty regularly. It's complicated. Keep the patient safe, steward the organ. Nobody knows what the right answer is because there isn't one. And where we get into trouble is when somebody wants a quick fix. There's no such thing, and this time won't be the same as last time or next time." With Mr. Chang, anesthesia didn't agree with cardiology, but they decided they trusted the surgeon. And okay, I would have liked it to go quicker, but then again, sorting through everyone's concerns maybe makes for a better decision in the end. So those myths, if we just all did our jobs properly, understood each other's roles, had clear leadership, all focused on the patient, Wilfrid's story illustrates that it's not that simple. These are all goods, and we should strive for them. But they're oversimplifications, and they can become ends in themselves. That's problematic because they cannot fix teamwork, in part because they narrow our focus to individuals knowing each other's roles, individuals focusing on the patient, etc. So what are some implications of all of this for health professional education? We've talked about truths, we've talked about two ways of seeing competence, and we've reflected on what I call some myths about teamwork and the complexity, the rich, everyday complexity of healthcare teamwork that those myths don't represent well. What does this mean for health professional education? Well, it means a lot, but I don't have time to go into all of it, so I've selected what I think is one of the thorniest implications, which is the implication for assessment. When we seek to assess trainees in health professions education, we use instruments like this. This is Rachel. She's an eMERGE resident. This is an ITER based on the CanMEDS rules, which is designed to assess, is Rachel a good collaborator? Does she demonstrate professionalism? Are her communication skills effective, etc.? This way of assessing is very firmly situated in an individualist way of seeing competence as an individual possession that's stable and context-free. And we have very little in the way of assessment instruments that would allow us to acknowledge the collective aspects of competence as a distributed capacity that's evolving and context-specific. So the assessment challenge boils down to this. How do we move from an exclusive focus on individual trainee performance, which is important, necessary, but insufficient, to a focus on collective performance? Well, our existing assessment approaches cannot get us there. And that's partly because our underlying metaphor for teamwork is wrong in education. Right now, the predominant metaphor we use for teamwork is the metaphor of the machine, that teams are a machine. And this is predicated on, you can see this in the way that we're interested in individuals. When you look at a machine, you want to get it to work better, you fix individual parts and you put it back together. The problem is that a machine is a complicated system and a healthcare team is a complex system. The difference is simple but profound. In a complicated system, the parts are key. In a complex system, the relationships among the parts are key. We need a new metaphor that lets us think more deeply about the relationship among the parts of a team. And there are some really nice candidates for such metaphors in biology and ecology. This is a video of flocking or murmuration, when starlings move as a collective in this beautiful, visually poetic way that you see in this video. Murmuration is not about individual competence. A handful of these birds can fall out of the sky, and this collective phenomenon will still happen. What does shape it, not the individual, what does shape it is features like geography and high winds. Do you see how a new metaphor allows us to ask completely new questions? What is the geography of a collectively competent healthcare team? What would constitute a storm for a healthcare team that would change its collective competence? This kind of metaphor allows us to focus not only on the individual, but on this notion of a collective performance. So in terms of the implications for health professions education, particularly related to assessment, we need to get beyond the parts to the relationships among them. We've started to try and do this in the last few years in a collaborative research program that I'm leading with Stephanie Seebach-Sire, who's now at Stanford. And we've begun to be interested in what we call interdependent performance and ways of measuring it. We started out by asking, okay, we're really focused on individual competence. So let's ask trainees and faculty, which trainee actions and decisions in a clinical teaching environment, in the workplace, in the emergency department, say, are likely to be a reflection of their individual competence. And it turns out that very few are. Trainee performance is only rarely described as independent, even by trainees themselves. More often it's described as interdependent. We heard stories like this from a trainee. The busiest night I think I've ever had to work, at 11 p.m. or so, the staff actually called me and said, look, I was just cruising the health record and I noticed you guys have a lot of consults. Do you have any questions? Are you worried about anyone? This trainee is interdependent with their faculty supervisor, even though that supervisor is not even physically present. There are a lot of entrustable professional activities that are framed as though they're independent, as though we are entrusting individuals to do them, when actually they're interdependent performances, like informed consent, which is in many clinical contexts an interdependent performance between the social worker and, in this case, the senior resident. So we recognize that healthcare trainees work on a spectrum of independence and interdependence. But assessment procedures, assessment, what I like to call orthodoxy, only partly tongue-in-cheek, assumes we're talking about independent performances. In fact, 30 years ago, social psychologists Kenny and Kashi said that interdependence is really just a statistical nuisance in measurement. We need to get past that to be able to talk about interdependence as a measurement construct, not as a statistical nuisance. We need models, indicators, metrics. We need a new language for interdependent performance assessment. And finally, what does this mean for interprofessional education? Well, let's look at the competencies. There are 6 competencies for interprofessional education: role clarification, team functioning, interprofessional conflict resolution, collaborative leadership, patient, family, and community-centered care, and interprofessional communication. This is a robust framework, and it guides most of the IPE curricular initiatives in this country, as well it should. But if we think about what is our current emphasis in IPE curriculum, I think most IPE educators and facilitators, and probably also learners, would acknowledge that our current emphasis is on role clarification and team functioning. Our initiatives are designed to help novices understand one's own and others' roles on the healthcare team and understand principles of team dynamics and group processes. And this is necessary and important, but also individualistic. Even in the language, there's a focus on what the individual will possess in their head and what we can assess them for individually, and understanding, for instance. There's an irony here that our description of collaborative competencies and our assessment of collaborative competencies is anchored in an individual acquisition mode. That's partly because we don't know how else to assess. If I'm going to assess an individual, I look at what they know and what they do and what they believe. Where we need to try and get to is to highlight interdependence and collective competencies within that collaborative competency framework. So that would mean talking about role overlap, talking about task duplication. So to understand one's own and others' roles, okay, step 1. But then to have experiences and reflections and learnings around how those roles may be in tension, how they may actually be shifting, with all kinds of examples in healthcare of adjacent professions changing their scopes of practice so that they overlap more, which creates all kinds of, kind of socio-political tension in healthcare. Structural interdependencies, we need to think more about things as mundane as scheduling, and things as abstract but profound as privacy legislation, which creates structural interdependencies which affect the way we collaborate. And fluid leadership and followership. What's interesting is that probably the best opportunities to capture interdependence and collective competence in the competencies for collaboration is when we're doing initiatives that are in situ, learning opportunities that involve clinical placements rather than work in the classroom or pre-clinically. But a scoping review currently unpublished that was led by folks in your Office of IPE found that in IPE programs in universities in this country, only 11% of universities had an IPE initiative that included in situ, in the naturalistic environment of the clinical workplace. 15% of universities had other kinds of initiatives. And it is actually a push now in many organizations to get IPE not only happening in the classroom, but also happening in clinical placements that are integrated and threaded throughout the learning trajectory. Looking again at the competencies, I think it's fair to say that less emphasis to date has been put on interprofessional conflict resolution and collaborative leadership. It may be because these are actually easier to engage with in the clinical setting than they are in the classroom setting. But what I'd like you to notice about these competencies is the potential they have, because even at the language of even at the descriptive level of the language we use, they invoke interdependence better than the cognitive language of the first two competencies that I focused on. So to actively engage self, other team members, and patient, client, family, this idea of engaging, that's interdependence. To work together for collaborative leadership and quality, that's interdependence. So I think as we emphasize curriculum development and assessment around these two competencies, we have a really great opportunity to start thinking about how we foreground interdependence. I also want to talk a little bit about our current situation in the world vis-a-vis the COVID pandemic, because I think that it has made obvious some aspects of collective competence that we couldn't see or wouldn't see before this. In 2014, Siobhan Nelson and Jeff Turnbull, sorry, that's an error on the slide, called for more critical discussions of scopes of practice in order that Canada could innovate to meet its emerging health human resource requirements. And they had some very provocative ideas about, really thinking critically about what scopes of practice were helping us do and what they were inhibiting us from being able to do. And if we look at COVID redeployments, we suddenly get a whole new perspective on scope of practice. So a few weeks ago, redeployments from home and community care support services into the acute hospital setting to deal with the third wave. So we have people in roles that they weren't trained for. We have redeployment orientation and training and a whole new attention to how a team should be set up in order to support people to be redeployed and work effectively in those new roles. When I was doing some research around this online, I was astounded by the amount of educational resources, high quality stuff that's been produced to talk about how we educate for new COVID context teamworks. There's one example from the Karolinska Institute on COVID-19 and the multidisciplinary team. Lovely videos for a number of different health professions and how their roles have been adjusted and adapted and in some cases expanded to respond to the needs of COVID patients. A lot of specialty organizations here, the Center to Advance Palliative Care has on its website examples of the roles of team members tailored to the COVID situation. And there's been some interesting work, including this study last year, of social media perceptions of who's on the healthcare team and how they're expanding because of the COVID situation and the spotlight it's been shining on all of the different roles in hospital that are involved in caring for this kind of a pandemic situation. So, back to the framework. I think has served us well for a number of years. But I think it's important because we know that educational transformation is required broadly in health professions education to produce graduates for a quickly changing health system, and really changing quickly in the last 12 months. As IPE approaches 50 years old, and it is, in the early 70s, you could find IPE work in the literature. I wonder if we should question some of what we're doing, some of what has now become status quo. And in the last few minutes of my talk, I want to touch on 3 issues that I think maybe deserve some debate now. The first is the question of our focus on profession in interprofessional education. In a scoping review published in 2020, Grace talked about models of interprofessional education and drew on this work by Yal and Pope from 2011, where they actually say that, the era of professions is maybe past, and a more helpful focus going forward, and mind you, for them, this was 10 years ago, would be on expertise, on networks of skilled individuals, rather than sets of skills possessed by an individual who represents a profession. So that's something to think about. What are the affordances and the drawbacks of retaining the lens of profession? There's actually quite a nice literature on this for us to consider. The second question I want us to consider looking forward is, what do we mean by leadership? So this really featured in the story I told you about Wilfrid Chang, but it's interesting that the literature on IPE rarely defines or conceptualizes or theorizes leadership. A number of authors evoke the term, usually in an individualist way, talking about positional or formal leadership roles on a team, and talking about the need for strong institutional leaders and champions. There are some nice contemporary leadership theories that have been worked on in nursing research that I think can be incorporated to advance the way we're thinking about collaborative leadership, which in some ways is an oxymoron, right? We have to wrap our heads around, what does it mean to be a collaborative leader? And I don't think we've taken that apart yet to the extent that we need to. And finally, the question of identity. Is there an interprofessional identity? Should there be? Professional identities are hard won. People are not about to give them up lightly. And I don't think we expect them to. But do we expect them to have dual identities? This is an emerging concept that's being discussed. Do we think there's a professional identity and an interprofessional identity? There's no shared definition yet in the literature of interprofessional identity, nor is there really a coherent description of how it would relate to professional identity. But I think this issue of identity is something that we need to tackle with energy in the time coming up in the next 5 years. So let me summarize where we've been on this journey together in the last 40 minutes. I've argued that how we see competence in health professions education influences what we believe to be true about healthcare teamwork, and therefore what we choose to teach and what we choose to assess. Individual competence is necessary. We all want individually competent healthcare providers, but it is insufficient for quality healthcare. Effective teamwork requires attention to both individual competence and collective competence. I've argued that we need new assessment approaches that can help us provide trainees with feedback on interdependence, their contribution among the parts of the team. And I think that with more integrated in situ learning around clinical placements, IPE could even better represent the complexity and the fluidity of things like professional roles in interprofessional collaboration. The competencies are a foundation, a strong foundation, and they provide us with a shared vocabulary, which is so important to move a field forward. Now we need to ask ourselves, how do we apply them in ways that highlight interdependent performances and move beyond a kind of an individual cognitive acquisition approach to competency assessment? These are the references that I have drawn on for this presentation. And I'll close by thanking you for your attention and telling you that I look forward to your questions and your comments.
So I just thank you so much, Dr. Lingard, for your insightful, relevant, and thought-provoking talk.